Well, first of all, I would like very much the organizers of Excellence in Pediatrics to thank them once again for inviting me here. This is my third meeting. I've been fortunate to be at all the meetings in Florence, London, and here in Istanbul, and it's a great honor and pleasure. I also would like to congratulate Peter for the tremendous job that Dimitri has done with the meeting. He has just taken it to another level. As most of you know or may know, in the United States, just about a week or a week and a half ago, the National Institutes of Health, the American Academy of Pediatrics, and the American Heart Association released national guidelines that suggested and indicated that all children should be screened for cholesterol between the ages of 9 and 11 and ages 17 to 21. I have to tell you that I prepared this talk before that recommendation came out, but at least I didn't have to change my slides. I'd also like to say that hopefully in the talk you will see why the panel, and our august moderator was a member of that panel, recommended that those guidelines be changed to universal screening. So I'm taking the pro position in cholesterol screening in children. The issue is to screen or not to screen. If we look at evidence supporting the association with disease as far as cardiovascular risk factors, it is clear that if we look at Category 1, in other words, Category 1, which are risk factors for which interventions have been proved to lower cardiovascular disease, cigarette smoking, hypertension, left ventricular hypertrophy, but notice LDL cholesterol. Evidence is epidemiologic, it is in clinical trials, it can be measured clinically, and it's useful. Response to pharmacologic therapy is there. So clearly, lipids are in the middle of useful cardiovascular risk factors in terms of their modification to try to prevent or intervene with cardiovascular disease. Approximately 50% of children who have their cholesterol measured in the 90th percentile, followed over time, will have elevated cholesterol over time. One of the issues that'll come up that Dr. Gilman may discuss is the issue of tracking, but I think it's pretty well given now that at least 50% of kids with high cholesterols will continue to have high cholesterols later in childhood and adulthood, at least 50%, so that indeed it does track. The Committee on Nutrition of the Academy of Pediatrics reiterated until these new guidelines came out about a week ago its recommendation that children with either a family history of high blood cholesterol or a family history of premature cardiovascular disease be screened for, have their children screened. In other words, selective screening. And they should be screened for a high blood cholesterol, those children. So we're talking about selective screening. So who again, in more detail, who again should undergo those selective screens? Those who have a lipoprotein profile in youth and whose parents and or grandparents required coronary bypass surgery or balloon angioplasty before age 55, have a lipoprotein profile in those with a family history of myocardial infarction, angina, peripheral or cerebral vascular disease, or sudden death before age 55, a total cholesterol in parents who have high total cholesterol levels greater than 240. If the parent's total cholesterol is not known, but the patient has 2 or more risk factors for coronary heart disease, and I've listed some of those, they should be screened. And then a latest one, if the BMI of the individual is above the 95th percentile. In regards, those are the people that should have selective screening. And what we're generally talking about for ballpark numbers for all of us are screening with issues where the total cholesterol is over 200, the LDL is over 130, triglycerides are over 100 or so, and HDL is less than 35. And some of the other specific numbers are listed there in terms of acceptable and borderline ranges. As early as the early to 1990s, a study of primary care physicians in the United States found that 76% screen at least some children for high cholesterol, and that 17% by that time screened all children for cholesterol. And that debate in the 1990s and early 2000s raged along in terms of difference in children's cholesterol tests. Well, I was fortunate to be a pediatric cardiologist at the Cleveland Clinic in northern Ohio in the United States. And I was able to work with our general pediatricians in the community in northern Ohio to see if an office practice in the early 1990s can effectively screen and identify preschool children with dyslipidemias. And to demonstrate that using family history will not identify 1/2 of children with severe elevations of cholesterol. So at that time, again, the recommendations were to screen with a family history where there was a myocardial infarction under age 55, and the parents had high levels of cholesterol. The problem with that, as we started to look at that data in the 1990s, was that the parents had no idea what their cholesterol was, or they had never had their cholesterol checked. If we look at various age groups, 18 to 34, 35 to 49, and we look at how many have ever had their cholesterol checks, the numbers got a little better as they got a little older into their 60s, but somewhere between only about 10 or 15% and 25% of young adult parents had ever had their cholesterol checked. They had no idea what their cholesterol was because it had never been measured. And so 65 to 75% of the parents had no idea what their cholesterol was, and we were finding that to be true in northern Ohio. So one of the major recommendations of the Heart Association was that if the parents have high cholesterol, 65 to 70% of the people didn't know what their cholesterol was in the parent. So the idea was, how could you screen if you don't know and the parents don't know what their cholesterol is? The other issue was a positive family history. This is the data that we did on 6,500 almost exclusively Caucasian children in northern Ohio, looking at their family history when their LDL was over 130 to 160, 160 to 180, and the area where we would, I think, consider treating today if the LDL was over 190. The red is positive family history, the green is negative family history. So in our study, 50% of the children had no positive family history. So in addition to the fact that 70% or so of the adult families' cholesterols weren't known, it was a flip of the coin. It was a 50-50 chance in terms of having a family history that identified you as having high cholesterol. Not a very good screening program when those numbers come out like that. But what we did determine on measuring children in this study with cholesterol levels of over 200 was that we could identify those that had lipid abnormalities. The mean cholesterol in our group at that time was 162, and that our 95th percentile was 214, numbers that agreed very nicely with the national data at that time. So that when we looked at the total cholesterol in 6,500 patients, we could identify those that had 185 or 186 to 200 or greater than 200, and we modified our approach based on the numbers that we found. Risk factors in diet, exercise, diet, and then repeat lipid profile in those with a cholesterol of greater than 200. As I said, the mean cholesterol was 162, and we identified 85% of patients based on a screening of a cholesterol that had elevated cholesterol and then had elevated LDL cholesterol. 8 out of 10 of our patients, or 80 to 85%, had LDL cholesterols greater than 130. So again, it wasn't just that we could screen with an elevated cholesterol. We found within that group that 85% had elevated LDL cholesterols, and we also found that HDL cholesterol as a factor in giving you an elevated cholesterol, which some people had said occurred 15 or 20% of the time that you had elevated cholesterol because your HDL was elevated, occurred only 5% of the time in our patients, in that series of patients. So what did we conclude from that study in the early 90s on 6,500 Caucasian children in northern Ohio? 85% of children with total cholesterol greater than 200 can be expected to have a definable phenotypic lipid profile. Only 5% of children with cholesterol greater than 200 will have HDLs over the 95th percentile. 8 of 10 children with their cholesterol greater than 200 will have LDLs greater than 130. Only 1/3 of the families of children with cholesterol greater than 200 will have a history of premature myocardial infarction, and 50% of such families have no family history of premature myocardial infarction or increased cholesterol. And that led us at that time in the early to mid-90s in northern Ohio to begin screening all children at the age of 3, because we couldn't rely on selective screening. If we're going to screen, then our feeling was we better screen everybody, because we're going to miss 30 to 60% if we don't. But that was the Caucasian population. What about other populations? Well, that same information has been found to be true in urban African Americans in the United States. This is a study that was done in African American adolescents between the ages of 12 and 20. You can see that if you add 19 and 26 and 8%, that's 32% would have had elevation of things that where you would want to look at those. However, only 25% of those kids would have had a predicted screen from the National Cholesterol Education Program at that time. So you would have missed, again, at least 10% of those patients if you would have just gone on the guidelines and not actually looked at what each one of those families had in the African American population. So it wasn't just the Caucasian population, it was the Anglo-American as well. But more important than that, 2/3 of those with LDL cholesterols greater than the 75th percentile and 60% of those with LDL cholesterols greater than the 90th percentile would have been missed with selective screening. In addition, there's a study from West Virginia that basically shows the same thing, done at a mean age of 11. I would point out to you the information on the lower part of the slide. Of the 29% in this group who did not have a positive family history, 10% had a dyslipidemia, and of that 10%, about 2% would have warranted pharmacologic intervention, would have been totally missed if one would have continued to go with the guidelines as advanced by the National Cholesterol Screening Program. Well, what's wrong? What's the problem with targeted screening? Why do we miss so many? Well, there's an inaccurate or incomplete family history of premature cardiac disease. Why is that? Well, at least in the United States, the number of single-family households in which the family history of one parent is completely lost. So you never get a complete family history. It's potentially compounded by single-parent households in prior generation, grandparents, creating gaps in family history. Adults who lack health insurance in the United States, creating what we call a donut hole effect in the insurance demographic. The donut hole in patients between 19 and 64 accounts for 80% of the non-elderly who are currently uninsured and leaves a huge information gap. The lack of knowledge about the parent's cholesterol. The Agency for Healthcare Research and Quality report that 39% of younger adults between the ages of 20 and 34 and 17% of all adults that they never had their cholesterol measured, ever. In uninsured adults, 33% reported that they never had their cholesterol tested. So again, how can you utilize some of that information then as screening tools when most of the people aren't getting it done? The National Health and Nutrition Exam Surveys reported similar findings in only about 1/2 of adults with hypercholesterolemia reported being told of the diagnosis. So they actually had it, and their physician didn't actually tell them about it. And again, the single-parent household is an issue. The other is that we think, at least to some degree, that adult health care providers are unaware of pediatric guidelines and tend not to enforce those. So there's a diagnosis gap based on data from electronic records from Scott White Clinic in Dallas and Henry Ford system, contemporary screening rates are low for cholesterol and other cardiovascular risk factors, probably less than 2%, not even at the 5% level. And this has led to the screening diagnosis gap. It's either the result of unintentional oversight, clinical decision-making that deemed it an inappropriate diagnosis, or overt decision of concern to omit the diagnosis in favor of a concern for future insurability. When I made up this slide, it was before the recommendation came out in the United States to screen kids between 9 and 11. I chose 10 because of the effect of puberty lowering the LDL cholesterol, but close to an age when if one needed to initiate drug therapy, it might be appropriate. And by the way, drug therapy would probably only occur in about 1%. There has recently been another meta-analysis of screening for dyslipidemia in a primary care setting, similar to what we did in the 1990s in Ohio, where the use of a total cholesterol detected 88 to 96% of cases and with a false positive rate of less than 1%. So in other words, screening is effective. It will identify those kids with elevated cholesterols and elevated LDL cholesterols. But the other thing that it does is bring attention to adult relatives who have greater coronary mortality than relatives of children with normal cholesterol. And if you combine that with blood pressure and BMI, it identifies more relatives at risk. So universal screening, we think, may be optimal while youth are insured, assuming it will not affect our insurability in the future. And universal screening, we feel, is more urgent given the epidemic of obesity and metabolic syndrome in American youth. The cost estimates of treating future coronary heart disease and the use of long-term drug therapy has changed dramatically in the last 20 years with the use of newer procedures that you can see on the screen, percutaneous intervention with drug-eluting stents, bypass, et cetera, et cetera. We have estimated that the cost for cardiac disease between 2000 and 2004 increased from 62 to 90 billion. And so it seems prudent to modify that in evaluating and screening if we can. So I think we know that hyperlipidemia is an established risk factor for coronary heart disease, and the origins of this atherosclerosis have been known on studies since the Korean War. Autopsy studies have demonstrated early features of atherosclerotic vascular disease in children as young as 4 to 5 to 6 years of age. An exhaustive systematic review for the U.S. Preventive Services Task Force concluded that 50% of children with elevated cholesterol will have elevated levels at follow-up. Screening based on family history and a high cholesterol in the parents will fail to detect 30 to 60% of children with elevated cholesterol. There is no data regarding the effect of screening children on adult lipid levels or disease outcomes, but those are studies that take a very long time to do and certainly need to be ongoing. And so I would leave you with this thought. When we screen, we should do universal screening. Thank you very much. Well, Matt gave an excellent review. I want to congratulate him on his overview. It was really excellent. A couple of comments. The fact that the National Review, when they looked at the issue of screening in 1992 and 1997, did not come out with universal screening. And just recently, a week and a half or 2 weeks ago in the United States, they did. I would say they finally got it right. They had plenty of years to study it. They looked at not doing it in 92 and 97 and realized that you just can't do it. Matt briefly mentioned some of the costs involved, and there's no question that any kind of a screening program in that kind of a universal way is costly, but I would suggest that the costs that I showed you in 2004 dollars of the ravages of cardiovascular disease, because someone doesn't have an endpoint, because there isn't a study out there that has tracked people for 60 to 65 years to show that if you identify them early and then modify things that you have an effect, because it takes so long to have that show up doesn't mean you shouldn't do it. It just means that the data isn't there yet to have that information, but it doesn't say don't do it. It seems reasonable to identify those patients at risk, particularly those with LDL cholesterols of greater than 190, and deal with those populations. And if you try to do it in a selective way, as I said, it doesn't work. It just absolutely doesn't work. The other is, Matt alluded to the fact that there is overlap in the adult population. People have myocardial infarctions at age 55 with normal cholesterol. But if you look at the population of people that have cardiovascular disease with significantly elevated cholesterols, that the incidence of cardiovascular disease in that population is very significant. And it isn't just an elevated LDL. There's more and more data coming out looking at what a low HDL really means in that setting as well. It isn't just high LDL. There's more and more data, and there's also some suggestive data, although not definitive, of the issue of triglycerides. As you know, they're inversely related with the HDL. The higher the triglyceride, the lower the HDL. But there's also some data to suggest that at least that is a worry as well. The other thing about the issue of doing this screening in a, say, a 9 or a 10-year-old or an 11-year-old, it isn't just lipids, and I always sort of get somewhat negative when somebody is just talking about lipids and cholesterol. It's an entire health screening thing that one does with the pediatric patient, hopefully before they get into adolescence. So it's looking at their lipids, but it's also their blood pressure, how heavy are they, do they exercise, do they smoke, what kind of family environment do they come from, what is their nutrition like, how much exercise do they get. One of the things that looking at lipids allows you to do is an entry point into an entire healthcare evaluation of that young patient before they get into adolescence. So it isn't just lipids, and if it's lipids by itself, I think that's a mistake. I think it's part of the entire health evaluation of that child. One of the things about, one of the complaints about screening has been they have to fast for it. Well, I just put up a slide that shows that you really don't, that fasting has a small positive effect for cholesterol, HDL, and LDL. It does have an effect on triglycerides of about 7 milligrams per deciliter, but only about 2 to 5 milligrams per deciliter with a 12-hour fast, so that really you can do these studies in a non-fasting state and really get very accurate information so the kids don't have to necessarily fast overnight. And the other is, well, what about somebody that's going to look at all this? How can we put all this together? Well, I think we now have, at least in the United States, some ways to do that. One of them is the Cardiovascular Research Network, founded in 2007, which is a consortium of 15 health plans that care for more than 11 million members, reflecting all demographic groups in the United States, health services, and insurance options. It's ideally suited to evaluate risk factors such as hyperlipidemia in the pediatric population. It can provide robust surveillance data for use of diverse races, ethnicity, and look at the risk factors across the nation in diverse healthcare setting. It's accessible to researchers, and important information on the impact of therapeutic interventional statin treatment. As was said, there is a body of evidence now, at least on short-term data, that statins are very well tolerated in the pediatric population. I did see that report on the New England Journal of Medicine, and certainly in any long-term drug effect. But we're talking about treating 1% of the population that we identify, and we're talking about modifications in lifestyle for the whole family with the others: diet, exercise, not smoking. We looked at a study at the Cleveland Clinic a number of years ago in women who had coronary artery disease at a mean age of 23. Very young population. What was their most important risk factor? It actually wasn't cholesterol, it was smoking. And the more they smoked, the more coronary artery disease they had. Lipids were important, but smoking was incredibly important in that young population. So again, I see the whole lipid opportunity as part of a health screen for kids at an appropriate time when one could do something about it. And finally, I'd just like to, and I mentioned the overlap in the adults. Finally, I guess I'd like to have ask a question to Matt in terms of what is he going to do now? The recommendations are out there from the Academy of Pediatrics, and I would ask you as pediatricians from around the world, most of you here not from the United States, what are you going to do with the recommendations from the Academy of Pediatrics, the National Institutes of Health, the American Heart Association, three fairly august bodies dealing with cardiovascular disease in children in the United States? What are you going to do? Selective screening doesn't work. Maybe Matt's approach and a population approach is the way we're all going to have to do it. But I would ask him and I would ask you, what are you going to do now? Thank you very much.